Hello to everybody. Welcome to this webinar, Arterial Stenting Tips and Tricks. My name is Christoph Lenger-Marx. I'm the clinical specialist from Optimed. And I will say hello to all around the world. We have got people now in the audience from everywhere in the world. So we have got two wonderful guests today, Dr. Balazs from the Center of Interventional Neuroradiology here in Bratislava, and Dr. Kožnar from the Fakultni Hospital in Prague. Welcome. So it's yours now.
Thank you very much for the invitation. Hello everyone. In this session we would like to talk about the endovascular techniques and strategies and about the aortoiliac and femoropopliteal lesion treatments. So as we know, when we would like to treat these type of lesions, always the big question is who is the best candidate and what type of endovascular therapy should they receive. In the decision-making process, it's very useful the task 2 classification, where all the lesions are divided according their complexity into 4 categories, and so we can choose if we are going for the easy cases for A lesions or the most complex lesions. These are the D lesions. Other factors we would like to take into consideration are the patient's factors and the comorbidities. If we have a claudication patient, we would like to work on the lifestyle improvement, the walking distance improvement, exercise therapy or risk factor modification. In these cases, we are more conservative, so are using more balloon angioplasty or drug-coated balloons. But in case when the patient has like critical limb ischemia, we would like to save the limb, or we have a limited life expectancy, we are more aggressive, so we are using scaffold, bare metal stents, or even drug-eluting stent technologies. So what are the guidelines? Over the past decades, major advancements have been made in the treatment of peripheral artery disease. The design and the quality of devices made it possible to have an endovascular first option for task A through task C lesions, and the toolbox expanded with several instruments, and now we have a growing evidence for task 2 D lesions, and they are now increasingly being handled by endovascular approach. And endovascular reconstruction was associated with a fewer major complications, with a shorter length of stay and greater improvement for the patient. In the situation of the aortoiliac arterial disease, the endovascular technical success rate is around 90% and over. For iliac artery occlusion, the direct stent placement or primary angioplasty with subsequent stent placement can be considered as a state-of-art treatment. In general, for de novo iliac stenosis, the primary stenting is favored, but provisional stenting is acceptable. The stenting is mandatory if we have flow-limiting dissection, residual stenosis over the 30% of systolic gradient, more than 10 mm of mercury is seen after balloon angioplasty. Basically, we have available 2 major type of stents, the balloon expandable and the self-expandable stent technology, where the balloon expandable stent is more precise, the self-expandable stent is more flexible, they have a better wall apposition, even when we are treating different, let's say, diameter of vessels. The key to success is the proper approach selection. Usually we are using the crossover approach from the contralateral side, but in specific cases when we would like to have more control over the case, we are using the antegrade approach or even retrograde approach from the transproprietal, transdorsal axis, or even from the brachial artery or the radial axis. So let's start with something really easy. In this case, we had a patient with the occlusion of the right common femoral artery, and in this scenario, we are co-working with our surgeons, so they asked us to create them an inflow and open up the tight stenosis of the external iliac. Here we used 2 self-expandable stents to open up the vessel. Another great scenario is when you have an occlusion. In this situation, we had the occlusion of the external iliac, and the intraluminal recanalization was successful. We ended up in the common femoral artery with a wire, and the lesion was stented by self-expandable stent with nice result. But sometimes complications can occur. You can see here on a CT scan, it was a patient with a kissing stent technology in the common femoral arteries and a really tight calcified lesion at the origin of the external iliac. So what we decided here to use the left transfemoral approach, try to advance the catheter through the lesion, but at some point you can see the dissection formed. We were not able to cross the lesion from the medial and the lateral portion of the let's say the vessel. So now you have to think about what to do. The problem was that on the right side we had this severe stenosis of the common femoral. In this case you can help yourself by puncturing in an ultrasound guidance to avoid puncturing the calcified plaque, and use crossover approach to see the situation. So you can see how tight and heavily calcified focal lesion was present in the iliac vessel. After we changed the diagnostic catheter, we used the steerable sheet. It's really useful. As you can see in between the first and the second picture, you can change the angulation of this steerable sheet and advance the low profile instruments through the lesion. First we tried 018, then 014 wire, followed by the balloon angioplasty to try a little bit open up the vessel. And after the balloon angioplasty, still there was a problem to cross the lesion from the retrograde approach, so finally we used the snare technique. In this next case, as following, you can see there was a tight stenosis still present, but finally we were able to enter it with a balloon expandable stent with a really nice result. In this scenario, we had the occlusion of the common iliac artery, and we used the subintimal dissection re-entry strategy, and as follows. You can see retrograde access again failed. We went from the crossover approach, used the steerable guiding, and entered with the same fashion with a low profile wire and the balloon, the lesion, and opened up the subintimal space. After then, you can try to cross with a hydrophilic wire this newly created lumen. Sometimes it fails, and you have to open up a little bit more this new channel from above to be able to enter it. So at one point we were successful by 4 mm balloon angioplasty, and with the retrograde access it was possible to cross it. After then, we implanted a balloon expandable stent followed by self-expandable stents. Another scenario, when you implant stent graft, sometimes it happens that one of the arms occlusion can occur. It was a patient with a subacute limb ischemia, 7 days old occlusion. After the retrograde approach, we used the pharmacomechanical thrombectomy. The principle is to inject pressurized saline through the catheter distal tip, and the macerated thrombus is aspirated then through the catheter port. So after the aspiration, we were able to clean up the left arm of the bypass, but you can see sometimes, usually at the top of the lesion, you have some thrombus or some more fibrotic tissue. Then you can use a stent to cover it, or let's say save the procedure to open up the left arm. In this scenario, which is the most complex, let's say, when you have to use multiple approaches, as you can see here, 3 access points. It was occlusion of the origin of the right SFA. And unfortunately, in this case, you can see the stent was protruding into the aorta. And in this situation, you have really problem to cross over your guiding sheet. So you have to think about what to do. You can go from above, try to enter it anterogradely, or from below, puncturing the SFA. So first, the integrated approach failed. So we decided to puncture the mid part of the SFA and retrogradely pass the lesion. But again, there was a problem because at the level of the common femoral artery, there was a problem to came back into the true lumen. So from the retrograde access, we used the re-entry catheter, which is equipped with a needle. So you can point yourself back into the true lumen at the origin of the vessel. So again, you can save your day by doing it in a retrograde fashion and followed by drug-eluting stent technology. So when we are talking about the femoropopetal endovascular techniques, we have a lot of them. We have balloon angioplasty, we have stent placement, atherectomy devices, and there's always a major advancement every year, and there's evolution of technologies, and we have just few head-to-head studies to choose what's the best for the case or for the patient. We have variable inclusion criteria and primary endpoints, and maybe a potential bias in the impact of the operator skill. So meta-analysis was conducted to determine the ideal endovascular strategy for femoropopetal peripheral arterial disease. And as you can see the results, the drug-eluting technologies are doing really great work, and they're reducing the TLR rate significantly. So what is our strategy for these type of lesions in the femoropopetal area? We are talking about the lesion complexity, what is the length of the lesion, if it's the calcium, if there is a long CTO, and how severe is the leg, if there is any problem on the periphery. So if there is a claudicant patient, short lesion, we usually using just a plain old balloon angioplasty followed by DCB. But if it's a more complex lesion, we are using the drug-eluting stent technology to use some scaffold. So after the pre-dilatation, if it's successful using DCB, if it's highly calcified with residual stenosis or dissection, we are using usually scaffold. This is an example. You can see short occlusion of the SFA, use balloon angioplasty. It was really nice. No elastic recoil, no severe dissection was present, followed by DCB. We are happy. And the next day, you can see an ultrasound, no late recoil or late restenosis occurred, so we are happy with the case. But as you can see, even the focal stenosis SFA is not guaranteed for the success. So as you can see, balloon angioplasty, I was thinking, okay, the job is done. We are happy. We made the balloon angioplasty. We can go home or for coffee. And oh, okay, there's a dissection. But I was really optimistic about this. So let's do some more balloon angioplasty. In 15 minutes, I was like, okay, it doesn't seem really good and nice. It was the dissection was filling up and closing the vessel. So in this case, you can use the scaffold technology and use for in this case, the drug-eluting stent to open up the vessel finally. So the problem is the calcium. There are some challenges. We know the Fabrizio Fanelli study in the circumferential calcium. We are losing the primary patency. There is a late lumen loss. We have dissection. You can perforate the vessel. So this is the major problem in the endovascular field if you are dealing with the calcium. So let's see the another vessel response. It's a mid-SFA occlusion, and in this fashion, we were able to open up just in a subintimal space with a re-entry catheter, and you can see here the vessel response was like some elastic recoil, dissection, and the drug-eluting stent technology saved the day. The vessel kept open. The other scenario, when you have a lot of calcium, even the balloon is not able to do the job, not able to dilate it properly, you can utilize the high radial force flexible bare metal stent technology, where after implantation with its radial force, it's able to push the calcium away. But here I would like to be a little bit controversial, because we have the drug-eluting stents, we have the strong bare metal stents, but the bare metal stents can restenose. And in this case, after the recanalization on the distal part, we use some high radial force bare metal stent, and usually they are so long, it's little bit complicated or hard to determine where the implantation will end. So in the proximal part, just to avoid the coverage of the common femoral, we are using the classical stents, for in this case drug-eluting stent, and this was the final result. And in 6 months later, the patient came back with short claudication, and as you can see, where the drug-eluting technology was, it was open, and in the bare metal stent region, the wrist stenosis already was happening, so the vessel was narrowing down. So both technologies has their advantages and disadvantages, and it's on the operator to think about, okay, what technology is the best in this case, keep it up longer, or go for really high radial force stent. But in cases like this, you can have in within 1 year a wrist stenosis. So this was after balloon dilatation and the final result. So, and in this last case, I would like to talk about this long task to this lesion. When you have really long SFA, popliteal, and the origin of the anterior tibial occlusion, and usually we are sending patients which has at least one vessel runoff into surgical ward to perform femoral distal bypass. But in this case, when you have a mid vessel occlusion, distal runoff is really poor. There was no other chance for the lady just to try to open up the whole closed segment of the lesion. So after we enter the superficial femoral with the O35 wire, usually the hydrophilic wire is used, accompanied by the balloon dilatation. Why? Because if we are opening up a really long segment, the friction during the crossover approach is really high. So by opening up the vessel below the interventional field, you can keep up the force, and you can advance the catheter further distal into the vasculature. At some point, the hydrophilic wire popped into the anterior tibial, and we were able to enter it into the only one vessel into the peripheral, and followed by O18 guide wire, balloon angioplasty at the origin and the mid part of the anterior tibial with a satisfactory result, followed by the SFA angioplasty. But as you can see there, when you have a really long segment dissection, you have to implant a scaffold to keep it open. So it ended up with the drug-eluting stent technology. And after the angio, I saw something distally. I was not pleased. There was a dissection at the origin of the anterior tibial. So while I was working on the top, the distal part recoiled. There was dissection, and here the balloon expandable coronary stents can help today, and a reconstruction of the ATA was performed by flaring the proximal part, and we were really happy that we had a quite nice flow despite the very poor vasculature, and some collaterals occurred in the peripherals. So we were like, okay, the procedure was really tough, but let's see what's happening with the patient. And this is the situation. So the baseline was in May. So the critical limb ischemia was really severe. Almost all toes were affected, and over the course of time, the last pictures came just yesterday. I asked the lady because I was so enthusiastic. Please send me pictures to see what's happening, and she was really happy. And only the big thumb small defect was present. So we are really happy about the case. So in some really challenging cases, it can save the day and save the limb. So as a conclusion, we can say that the endovascular treatment for the arterial artery lesions proved to be safe and efficient, with excellent primary and secondary patency, regardless of the complexity and occlusions defined by the Type 2 classification. In well-selected patients, the endovascular therapy can be the treatments of choice, even in complex iliac lesions, if performed by experienced endovascular interventionist. And in the femoropobital lesions in selected patients, the DCB provides better primary patency and TLR, but it really depends on the vessel response. If we have a dissection, elastic recoil, or we have a CLI and the comorbidities, we need for more aggressive treatment and the drug-eluting stent implantation, which demonstrated superior primary patency and reduced TLR, even in challenging lesions. And I see that the drug-eluting technologies may play a expanding role in endovascular treatment of peripheral arterial disease. Thank you very much.
Thank you very much. It was very, very interesting.
Thank you.
So during your presentation, we've got some questions
Okay.
for you all. You can ask question for the Slido app. You will see on the top there a QR code. You can scan it with a mobile phone and ask questions, and so we will answer them. So the first question is drug-eluting balloon versus stent. Which one is better? Which one you prefer? This question is on both of you. Doesn't matter what I use, what is the best?
Okay. So let's say it's really about the how the vessel is reacting to the primary balloon angioplasty. So the first thing, if we have a relatively short stenosis, and after the balloon angioplasty we are really happy that it result. Usually it's followed by the drug-eluting balloon. And in young patient, if we have the areas which we don't want to stent, for example, or we have patients who cannot receive dual antiplatelet therapy, all these technologies are let's say, in favor of balloon angioplasty.
Okay.
I prefer drug-eluting stents in superficial femoral and popliteal artery. And when we use this stents, we haven't restenosis and we haven't reocclusion after our procedures. I prefer this
Okay.
instruments.
Oh, thank you. And when we talk about drug-eluting balloons, we go a little bit over to balloons, balloon dilatation. For how many minutes you will do it, or depends. Okay, what is the reason why that's an occlusion, or what do you think?
When we use drug-eluting balloons, we insufflate this balloon 2 or 3 minutes. I think that that is sometimes needed for extraction for paclitaxel from balloon to wall, to artery wall, and I prefer to maybe 3 minutes.
Okay, thank you.
And but I really prefer stents. I hope that this is better what we prefer for patients. For me.
Okay, thank you.
Yes. Yes,
You agree?
Yes. I would like to add to Borek that really we like drug-eluting stent as well, and especially in a critical limb ischemia patients when we really would like to keep up the flow to the peripheral vessels.
Yeah.
So I was a little bit just made a comparison that when we have a young patient, short lesion, no defect, just claudication patient, maybe the more conservative is as a first stage therapy. And after then we can go for stent implantation. But if we have a really poor patient, poor vasculature, the leg is really not healthy, a lot of ulcerations, then the drug-eluting stents, I really agree, are the best choice.
Okay.
Yes.
So now only one question, then your presentation will start. So we talk about stent lengths. Only where the stenosis begin and ends, or what happens if we also partly stent it in a healthy arteria? What do you think?
Yes, it's a really good question because sometimes we have spot lesions. And what to do now? So we have the proximal, mid, and the distal part of SFA. And if you have, for example, the spot stentings, then sometimes when you have a reocclusion, it's really pain to reopen this vessel. Maybe you can agree with me.
Yeah.
So If you have two lesions close to each other, we usually tend to stent both of them and not leaving the gap in between them.
Okay.
If it's not really long, if it would be really long, like 30 centimeter, maybe we keep a gap, but it's not usually what's happening recently in our cath lab. Usually the re-intervention is much more easier when the whole segment is stented at once.
I prefer maximal 10, 15 centimeters for stent. When lesion is longer, we usually use stent grafts via bone.
Okay.
It's I don't know what is perfect, but a long lesion is very problem with restenosis, and we usually use stent graft for long lesions, for occlusions, especially.
Okay, thank you.
Yeah.
But now everybody is happy to see your presentation, so the stage is yours.
Thanks. Hello, everybody. I would like to demonstrate some three interesting patients, and usually this lesion are easy, but can also be very complicated, and this three patient will be complicated, or are complicated. This first patient is 79 male smoker, diabetics with gangrene all toes. 1 week before we perform unsuccessful intraluminal recanalization popliteal artery. Now we plan subintimal recanalization popliteal artery. There are heavy calcification all arteries, short massive calcified occlusion of popliteal artery, patent but stenotic all three crural arteries. We use 6 French long sheet, Outback instrumentarium, V14 wire, for predilation, drug-eluting balloon 4 millimeters. After this predilatation, we use a shockwave balloon. Next step was supera stent, and post-dilatation we perform with balloon 6 millimeters, but 24 atmospheres. There are heavy calcified lesion in popliteal artery and massive short occlusion popliteal artery. We use Outback instruments, V14 wire, and predilated this lesion with 4 millimeters drug-eluting balloon. After this balloon, we use shockwave 6 millimeters balloon, and this first is after shockwave balloon. We use supera stent. I think that is kink resistant, fracture resistant, and this is stent with high radial forces. And after implantation stent, we dilatate this lesion popliteal artery with 24 atmosphere, and result is very good. There are three crural arteries to peripheral. Second, our patient is 74 male diabetics with gangrene of toes. This is patient where we use stent for proximal lesion superficial artery. In distal femoropopliteal artery we use balloon, and for recanalization popliteal artery we use stent grafts. We use 6 French sheet for proximal lesion drug-eluting stent 7 millimeters, and balloon 6 millimeters. For femoropopliteal segment, we use 6 millimeters drug-eluting balloon, and for recanalization popliteal artery, we try use 4 millimeters balloon. But this PTA procedure in unsuccessful recanalization, probably for fresh thrombotic occlusion, we use stent graft and again post-dilatation with 4 millimeters balloon. Final result is I think that is proximal and proximal superficial artery normal, distal popliteal artery is also normal, and adequate femoropopliteal segment, and only one crural artery. This is a mirror angio in proximal tight stenosis in proximal superficial femoral artery, occlusion in femoropopliteal segment, and occlusion distal popliteal artery, and patent only one crural artery, and fibula. This is fibula artery. This is drug-eluting stent with balloon. In femoropopliteal segment, we use 6 millimeters drug-eluting balloon with fine result after PTA, and this is distal popliteal artery after dilatation with 4 millimeters balloon, and after dilatation is popliteal artery again occluded. We use 5 millimeters and 5 centimeters long stent graft via band, and after the procedure is normal superficial artery, fine result in femoropopliteal artery, and normal distal popliteal artery, and only one crural artery to peripheral. Last patient is 80-year female, which we perform many interventional during 2 years. First is in March, 20 years. And this interventional was for short claudication. 1 year before, we perform PTA of right pelvic arteries, and now there are stenosis of pelvic arteries and stenosis of superficial femoral artery. We use 7 millimeters drug-eluting stents, and for iliac external artery, 7 millimeters short drug-eluting stent. We use 6 millimeters balloon. After this procedure, we use dual anticoagulation. There are some stenosis in common iliac artery and iliac artery. We use two drug-eluting stents and balloon 6 millimeters. Result after this is very fine. 9 months later, patient with 3 days lasting rest pain of left leg, probably fresh occlusion pelvic arteries. We tried to perform crossover recanalization, but we deformed of proximal part of stents in iliac common artery. In the end, we recanalize pelvic arteries from left side. We use 7 French sheet with stent graft 7 millimeters and balloon 6 millimeters again. This is occlusion on left pelvic arteries, and we deformate this stent in origin arteria iliaca communis. We puncture left side, and we use stent graft which protruded 2 millimeters to abdominal aorta, and this is again a fine result after recanalization pelvic arteries. 6 months later, we perform PTI superficial femoral artery with 4 millimeters drug-eluting balloon for stenosis and dissection of on origin and proximal superficial artery. We used atherectomy device HOC1 and again drug-eluting balloon of 4 millimeters. After PTA, we have fine result, and pelvic artery is normally patent. There are stents on pelvic arteries, normally patent, superficial femoral artery with stenosis about 60% occluded with middle part. We use 4 millimeter stents, and proximal part or superficial artery, we use HOC1 atherectomy and post-dilatation with 4 millimeters bone. Fine result in superficial artery and femoral common artery. There are occluded in middle part profunda artery. 5 months later, again occlusion pelvic arteries, new stenosis of distal part of iliaca externa, dissection from proximal superficial artery, tight stenosis profunda femoris. We use again drug-eluting stent 7 millimeters for distal iliaca externa 6 millimeters, and for femoral common artery, we use short 6 millimeter stents. Again, 6 millimeters balloon. Now is patient without claudication on dual plated therapy, and possible problem of this patient are intimal but small hyperplasia on pelvic stents, gracile female arteries, and poor runoff. This is again occlusion. We crossing this occlusion without the formation of implanted stents. We use next two stents, and when we look, you can see some small hyperplasia between implanted stents. It's all. I hope that will be final recanalization in pelvic arteries, and I hope that is final cut down.
Thank you very much. It was very interesting. Both presentations were fantastic.
Thanks.
Thank you.
And during your presentation, we've got some questions. The first question, you talk about the difference between balloon expandable stents, self-expandable stents. You tell that the balloon expandable stents are better to place. What did you think about stents with an anti-jump technique?
Okay, it's a good option, of course, because for example, we compare between balloon expandable stent, and we would like to merge the two words together to be precise, and on the other side we would like to be flexible, so we can use the anti-jump self-expandable stents. So it's a very good option.
Okay, brilliant. Have you experience with that? Or
I prefer self-expandable stents, and when balloon expandable stent, I think that is only for renal artery and iliaca common artery.
okay.
This is, for me, this is only this one arteries for balloon expandable stents.
Okay, thank you. Now we change a little bit, because the next question, I think it's very interesting, because I think everybody has got his own view on it. It's about anticoagulation. Heparin, bolus, what after the intervention? What did you prefer? Flaxparin, Lovonex, or Xarelto, clopidogrel? What did you prefer? What did you think?
We routinely use 5,000 units of heparin for all interventions, and after our intervention, we use minimally for 3 months dual antiplatelet therapy, and for all time we use usually only 100 milligrams anopirin, acylpirin, and this one.
Okay, thank you.
Yeah. During the procedure, very similar, the 5,000 units of heparin administered to patients, usually into the sheet. Once it's punctured, we insert the sheet and then put the heparin. So the patient is during the procedure safe and no thrombosis occurs. And after the procedure, it depends what type of material got the patient. For example, in the iliac region, if you have bare metal stents, we sometimes administer just 1 month dual antiplatelet therapy, and on the other side, in the drug-eluting stent field, up to 6 months, for example. So 100 milligram anopirin and 75 milligram clopidogrel.
Okay.
Follows half a year after the drug-eluting stent implantation.
Okay, maybe that help the people who are watching the webinar because they're asking sometimes, oh, what should I give?
Yeah.
Very good answer. Thank you for that.
Yeah.
Now the next question is really totally different. So you know that a lot of people have got kidney problems, and that an alternative is a CO2 for the angio. Did you use it? Have you experience with that? What do you think about it?
Yes, we are using it in cases when you have patients with really severe kidney disease, and this is the great option. The advantage, maybe you can agree with me, that you can nicely see the big vessels. So you have to stay below the diaphragm, so you can see the iliacs, the femoral, but in a very peripheral vessels, the visibility is not so well. So we are tending to use it for the iliacs and the femoral-popliteal lesions. And sometimes I see when I a little bit overdose the patient with the CO2, the vessels tend to have some spasm. So yeah, it really depends on calculated to do it efficiently, and it's really helpful. Yes.
Okay.
I agree.
Okay.
Of course.
Short answer.
I'm very happy.
That's most of the best answers, yeah. And now one other very important question, very interesting question came. Sport and stents.
Okay.
Are patients allowed to do sport, or should they stop doing sport after they got a stent? What's your experience with that? Have you got anything with that?
or I can say vice versa.
Yeah.
We had one patient, and he came back each time after stent implantation. Okay, again occlusion. It was a femoral popliteal segment. They made already study that if you have a straight leg, the different angulation of the vessel. If you are sitting, they start to bend the vessel, and if you are gardening, the S shape occurs in the femoral popliteal region, and it really is destroying the stents. And this guy, he was an auto mechanic, so he was destroying his own stents by kneeing and up, and so it was about his job, and we had to take measurements for him. So it really depends which patient, how he's working in everyday life. Yeah,
Okay.
it's important, but usually we are telling them, okay, we are putting you a stent until it's made an epithelialization, so it needs a few weeks. Please don't bend your leg severely because you had got a stent into the popliteal segment, but it really depends what type of stent he got. If it's a super stent, kink resistable stent, it's really okay because he can move with the stent, but if it's, for example, the drug-eluting stent, it is not so kink resistant, so it might kink and might thrombose. So it's really case dependent.
Okay.
Now stents are very flexible, and I think that's no problem with stents in superficial and popliteal artery. when we use first generation of stents, self-expandable stent, there are stents very rigid, and I think that is with this all stents in superficial and popliteal artery, there are problems, occlusion, fracture, and now their stents are very good
Okay.
for this intervention.
Thank you.
Yeah.
I think this helped a lot of people because this question was asked, and so thank you for that.
Okay.
One thing I have got on my tablet is now a very nice webinar. This is one thing. Thank you for that. So I would say thank you to you both. It was a pleasure for me to have you here. It was a pleasure to be here in Bratislava with the company Optimate and to make this webinar. I say thank you to everybody outside who watching this webinar. You can see the webinar next week also on our YouTube channel. It's Optimate Education. So follow us and you will see all the newest webinar we make in the future. So thank you to everybody. Thank you to you both.
Thank you.
Thanks.
Have a good rest of the year. Fantastic Christmas time and all the best. Stay healthy. Thank you very much.